Right, so this afternoon we have with us Dr. Lesley Storey, Senior Lecturer in Psychology at, I'm not allowed to say Cambridge University, I've got to say Anglia Ruskin University in Cambridge. And you're going to talk about a qualitative analysis about quality of life with a GIST diagnosis. Is that right? Lots of quality. So I will hand you over.
Thank you.
We'll do a Q&A afterwards.
Yeah, that's great. Thanks. Can everybody hear me okay? Yeah? Okay, so this is amazing. I've got somebody to help me here. This is kind of unusual for me. I usually have to do everything myself. But first of all, I'd like to say thank you very much for allowing me to come and talk to you. And I will also be upfront about my hidden agenda. It's not so hidden. I'm going to talk to you about some analysis that we've been doing on a data set which we collected some time ago. But I also hope to get your views on our research and also kind of sort of where you think we should be going with our kind of future sort of program of work as well. So that's kind of sort of my hope that I can get something back from you guys, but hopefully you'll also find this interesting. So let's get started. So yeah, thank you. I can't do the Chris Whitty thing. Next slide, please. So in terms of what this analysis is based on, a few years ago we collected some data from a wide range of sarcoma patients. So obviously GIST is a subset of sarcoma, and this was a study which was funded by Sarcoma UK, and we were using that data as part of a way of creating a quality of life measurement index, right? And we eventually did that, and it's called SAM, which is Sarcoma Assessment Measure. But as part of that process, which was quite a lengthy process, and we did lots of different things, and indeed some of you may have been part of that and contributed information to it, we actually did some interviews and focus groups in which we asked people about their experience of having this particular type of cancer. And what we did afterwards, after we'd finished collecting the data and actually creating our measurement, what we did was we actually sort of thought, well, we've got all of this qualitative data, we've got the data from the focus groups and the interviews, maybe we should try and do something with it. So we did do some analysis, and what we did was we broke it down by subset. And one of the things that we were very clear that we needed to do was we needed to actually look at GIST by itself as a separate kind of sort of condition. And part of that is because we know that GIST is a bit of a kind of forgotten kind of sort of cancer in terms of kind of sort of the ways in which, with rare cancers, it's, there's a problem because obviously we've got a small kind of sort of sample of people, but particularly GIST seems to be something that people, first of all, they've never heard of it. I'm sure you're all familiar with this. But also kind of sort of, in terms of research focus, it can be a bit of a forgotten cousin sometimes. So we took this subset of this data, this bigger data set, and the participants that we had were 10. So it was 10 interviews that we took. And that's kind of sort of, you're probably thinking that's not very many. For qualitative work, that's normal. Having a small sample is kind of sort of the way in which we do it, because we're not looking to do things like generalizability. We're not looking to actually sort of, use that information as a way of kind of sort of making, sort of big changes or whatever in the same way we would if we were doing a clinical trial. But it lends itself to have this small sample size. So we had 10 interviews, and we had 8 male, 2 female, and the age range was 40 to 73. And most of the people who took part were actually part of a couple. So, and what's interesting actually for us here is that normally it's the other way around. Normally we get more females taking part in this sort of study than males. So it's interesting that we've got that kind of sort of 80-20 split in that direction. Thank you. So in terms of what we were doing, we audio recorded all of the interviews and transcribed them. And what we found as we were analysing it, and this analysis has taken quite a long time, we've been doing this for quite a while, this data was collected a good few years ago now, is that we found that there are a number of themes. So we did there's a process of analysis called thematic analysis, which we used. And we had 2 main types of themes. So we had themes which were common to all of our participants, and we had themes where the ways in which the experience of having had that GIST diagnosis, and indeed everything that came after it, was influenced by pre-diagnostic circumstances. And the issue with that is not so much that sort of we're kind of sort of tracking back to before diagnosis, but it's also because what it tells us is that there is something about where you're at in your life stage which is important and we need to pay attention to when we're thinking about, how GIST affects people. So depending on kind of how old you are, depending on kind of sort of what your circumstances are, and depending on kind of where that is in terms of, the point at which GIST is diagnosed and then afterwards, that really seems to have a big effect on kind of sort of the impact that it has on people, but also maybe some of the skills and coping strategies that they have in place in order to be able to deal with that. And I'll tell you a little bit more about that as we move on. So we have the 5 themes, the 5 kind of sort of general themes. And the common themes which we had for everybody, and I'm sure a lot of this is going to be very familiar to you guys. Theme number 1, problematic diagnostic pathway. Right, so that people having problems getting diagnosed, people having delays in diagnosis indeed. Theme 2 is about the quality of life post-diagnosis. And part of that is also sort of looking at sort of how that affects the ability to think ahead and plan for the future. And then theme 3 is about relationships and support. So what I'm going to do is I'm going to present some data for each of those themes, and I'm just going to split out the themes before I get started. And the data is quotes from the interviews from people who took part. Right. So what you will see, I'm not going to read them all out because obviously everybody can see them on the screen hopefully. But what I'll be doing is indicating sort of what we are identifying as particularly important. So those were the common themes that affected everybody. We also had these stratified themes which were very specific to, if you like, subgroups within our small sample size. And those were issues to do with occupation and financial impact, and the second one was sexual experience. And I'll explain kind of why they were stratified themes when we get to those. So, theme number 1. So this is the problematic diagnostic pathway. So what you have is a situation where only one of our participants had their diagnosis as a result of already being under the care of a medical professional. That was unusual, and that is probably representative that that's unusual. So what we got is, people who approached their GP or other kind of healthcare professional and got a diagnosis, but it was not the correct diagnosis, it was a non-GIST diagnosis. And then you've got this kind of sort of this lag in terms of actually sort of getting from that initial kind of sort of starting point and actually sort of the time it takes to get from there to actually get to the point at which the official, correct diagnosis is made. And indeed, what we've got here is that the longest time period was actually 15 years, which is, horrendous, in terms of having taken that long. And what we also see in terms of people talking about this is that it isn't kind of sort of just, people are waiting kind of sort of, and it's all very calm and so on. It's actually people are trying to manage their symptoms, and what tends to happen, or what seems to be in terms of how this operates, is that actually there is a crisis of some sort, and indeed sometimes it's an emergency admission and so on, and that's what actually sort of is kind of sort of the pivotal point at which the diagnosis takes place. So we've got some quotes here in terms of kind of sort of for example, somebody saying that the GP kept on giving them indigestion tablets. Then we've got somebody saying that after a 3-year period that they were misdiagnosed with bowel cancer, and then we've got somebody just talking about the fact that actually the symptoms that they're experiencing were just tiredness. They found themselves getting more and more tired. And then you've got again these kind of sort of physical symptoms that people were identifying prior to their diagnosis, and actually sort of giving that information about kind of sort of this idea that the route to diagnosis was not straightforward. Now, this is not unusual for a rare cancer. This is something that you'll all be familiar with, and it's something that we see over and over and again in rare cancers. However, the reason why this is included here, and the reason why this is important from a quality of life perspective, is because it sets the scene for what happens next. And what we have found in terms of talking to people, not just patients, but patients who have a rare cancer and have this kind of sort of problematic pathway, is that actually it reduces the level of trust in healthcare professionals, and particularly the level of trust in primary care. So, if you have spent a number of years going backwards and forwards to your GP saying that you don't feel well, something's not right, and actually their only response is to give you indigestion tablets, at the point at which you then are confronted with the fact that you have a serious illness, it's kind of sort of quite natural to then feel, actually, they've missed this, I'm not sure I trust this person anymore, right? And we all know, that that GPs don't see just patients very often. But of course, if you're the 1 in a million that they do see and they miss it, it's understandable that there's a psychological impact there. So this is not about sort of, bashing GPs or anything like that. It's just about recognising that actually the quality of life impacts and the psychological impacts start even before diagnosis because of this problematic pathway. Okay. So, as I mentioned, sort of in terms of what happens at the point of diagnosis, quite often you get this kind of sort of acute crisis, and that's what precipitates the actual, correct diagnosis at the time. So you've got people talking about going into A&E, collapsing, being taken into hospital, and actually sort of, actually then getting their results. Okay. So, in terms of what happens after that, right? So we've got this situation where we're now sort of at the point at which people know that they've got GIST, and they actually sort of have maybe sort of started their initial treatment. We then get people talking about this link between their physical state and their emotional state. So what you've got is this sense of kind of sort of people actually sort of linking problems with, feeling unwell, having a bad day, feeling maybe tired or whatever, and actually that then having a negative impact onto on their psychological well-being. So in terms of how that's working is actually sort of people actually sort of, we can see it's, particularly sort of clear cut in terms of the comment in the second quote there. My mental health is adversely affected when I think I'm going to die soon. I think I'm going to die soon when, for instance, over the last month, I was in pain for 10 days. So you can see, and that person is doing a really good job of spelling out what those connections are, right? That actually sort of, they're unwell, their mental state is poor, and actually what it does is, their mind is going to the worst case scenario. So actually, rather than just saying, yes, I feel low because actually I'm not feeling very well, I'm in pain, and none of us feel great when we're in pain, do we? So, that's kind of, that it doesn't even matter what the nature of the pain is, but actually what we're getting here is the ways in which people are making sense of those physical symptoms is having a negative effect on their healthcare and their emotional well-being. And one of the things, I was actually talking to some patients, some sarcoma patients recently at the Royal Orthopaedic Hospital, and one of the things that they described to me was this sense that they had turned into hypochondriacs, right? So actually what they were saying was that actually sort of every little tiny thing made them think, is this it? Is it coming back? What's going on? And actually, and obviously, and that's kind of sort of, you can understand that that's a reasonable kind of sort of way to actually respond to kind of physical problems. But of course, what's happening there is your mind is going to the worst case scenario. So, if you have a pain in your leg, rather than actually sort of stopping and thinking, well, maybe did I bash myself a little bit yesterday? Is that what's causing it? Actually, that isn't what happens. That process of appraisal goes straight to the worst case scenario. And of course, when you go straight to that worst case scenario, what you then get is anxiety. What you then get is the lack of ability to sleep. Actually, sort of feeling generally kind of sort of kind of sort of not in a great place in terms of the emotional kind of sort of ways of thinking about things. So what we've got in terms of kind of sort of this kind of sort of post-diagnostics condition is people actually thinking about their physical well-being and actually making sense of that physical well-being in a way which actually effectively damages their emotional well-being, right? So that's kind of sort of, again, what we're interested in then, one of the things that we are concerned about. The other thing, we have the next slide, thank you, is actually sort of, in terms of people thinking about how they actually sort of want to go about their lives. So hopefully, for some people at least, they've had surgery, maybe the surgery's been successful, or maybe they're on daily chemotherapy tablets, and actually that's hopefully keeping everything under control. But in terms of kind of sort of thinking about how that impacts with your life and actually what you want to do, this is something that came up a lot in terms of actually people identifying things that were important to them, activities, social events, sporting activities, which they used to do and which they now feel that they can't do anymore, either because they've been advised against it by a medical professional, or because they're making a kind of risk calculation that this is not something which is going to be a good thing to do. And actually sort of what you get is not so much people sort of saying, okay, well, this is a trade-off, but actually sort of, again, sort of, having that sense of this is part of who I am, right? I used to be a person who rode a motorbike. I used to be a person who did winter sports. I used to be a person who actually was very active in terms of how I lived my life. And then all of a sudden finding out actually that they can't be that person anymore. So again, this is not people sitting down and complaining about the fact that actually there are now physical constraints and limits on the ways in which they live their life. It is more to do with a sense of, who am I now, right? If I'm not that person who actually used to be the biker, then who am I now? Because actually, if we think about, the ways in which we consider ourselves and define ourselves and actually sort of make sense of ourselves, particularly in terms of social environment, one of the ways in which we do that is actually think about kind of sort of the activities that we actually pursue. So it's not quite as extreme as saying I am what I do, but generally, if we're thinking about leisure activities and valued activities, quite often those tend to be things which actually allow us to make sense of who we are and give us an identity. I am an active person. Right? But it's also about that ability to connect with other people, because a lot of these activities are activities which are not just done solo and actually sort of kind of sort of without other people around. So in terms of thinking about what this is like, so if somebody, for example, used to do winter sports, generally, and we know from the rest of that interview, they used to do those with other people, right? They didn't just do them by themselves. And actually, when people talk about this impact on these valued activities, it is partly that sense of kind of sort of, I'm not that person who I used to be before, but it's also, it cuts off an avenue for social connection. Right? So again, thinking back to that sort of that sense of kind of sort of opportunities for social sport, opportunities for us to kind of sort of connect with other people, even if it's not necessarily a deep and meaningful relationship with that person, but actually sort of, having that social network, knowing that those people are around, maybe seeing the same people every year when you go snowboarding or whatever it might be. And one of the things that we know, I was talking at lunchtime about sort of about our experiences during lockdown. We all found out the hard way during lockdown that those kind of sort of everyday social connections were much more important than perhaps we'd given them credit for. And actually, when we lose them, we lose something else. We lose more than just kind of sort of that everyday kind of connection. So what we're getting here is information. And one of the reasons why this is something that we asked about and we were interested in finding out people's experience about is because when people have conversations with their healthcare professionals, this is the sort of thing that doesn't tend to get asked about, right? So if, when somebody is giving information perhaps, to an allied healthcare professional or their surgeon or their oncologist, they will ask, questions, about, your life, kind of sort of, who you are. But actually sort of this idea that, those leisure activities, those kind of everyday activities which are part and parcel of who you are, they tend to get sort of, shifted to the bottom or indeed not asked about at all. And one of the things, for example, that we have found in terms of bone sarcoma, where people are possibly considering having to have an amputation as part of their treatment, is it matters who they are at that point, right? So if you are somebody who's quite athletic, has lots of kind of sort of physical hobbies and so on and so forth, you might make a different decision about the treatment pathway that you want compared to somebody who sits inside and reads books all the time, like me, right? So actually, that is something that needs to be part of that conversation with healthcare professionals, and it can't be if healthcare professionals are not alert to that and aware that this is something that they need to know about. So again, that's something that's one of the reasons why we were asking about that. So I mentioned in terms of kind of sort of this idea of what happens after diagnosis and this negative impact in terms of quality of life. But actually, one of the things that came out of this was the idea that people are struggling with the idea of how to plan for the future. So in terms of thinking about this, it's partly to do with fear of recurrence, but it's more than that. It's bigger than fear of recurrence. It's about this idea that actually I'm now, again, not quite the person that I thought I was. The constraints that are there for my life are different, and actually what that means in terms of how I think about the future. So it's not just in terms of kind of sort of maybe thinking about the future as being slightly shorter than people may have generally envisaged, but it's also about this idea that that impacts on in a very real way on actually everyday kinds of decisions, right? So I've been in conversations with patient groups where they've talked about things like living from scan to scan. So this idea that, life consists in sort of the chunks of time in between scans, and actually, that's the only kind of sort of time frame that they have available in order to make a decision. So those kinds of sort of planning ahead types of decisions that we tend to take for granted. Am I going to go on holiday in 6 months' time? Shall I book tickets to go and see Taylor Swift? No. Right? No, because actually those things quite often are a year ahead or 18 months ahead. Or, even holidays, right? If you don't want to leave everything to the last minute, perhaps it's somewhere that gets booked up quite quickly, you might need to book that, quite some time ahead. And if you are kind of living with this kind of sort of sense of actually my life is not the sort of life where actually I can just assume that everything will be okay in 3 months' time, everything will be okay in 12 months' time, then actually that makes a big difference to kind of sort of how that then works in terms of thinking processes, but also kind of the negative aspect of that. Because even if everything is okay, even if, treatment has been successful and so on, what that means and what that results in is that sense of kind of sort of always having to think about your life in terms of, oh, yeah, I've got gist, right? So rather than actually being able to say, actually, I want to go on holiday in 6 months' time, can I afford it? Can I get the time off work? Will my partner be able to get the time off work as well, right? Those are kind of sort of everyday ways in which we make that kind of decision. Actually, what's happening is, oh, I have to think about where that fits in terms of my treatment. I have to think about whether I've got a scan coming up. I have to think about kind of sort of what might happen if that scan result is not great. I have to consider where I'm at in my follow-up program, what my checkups are like, and so on and so forth. And what that does is it means that all of those decisions, big and large, or small and trivial maybe, are always informed by the illness. So any kind of sense of kind of sort of, I'm going to forget about it and get on with my life, right? That might be a bit optimistic, but any kind of version of that is taken away, right? It's not really an option. And that's something that we were really interested in terms of actually sort of how this was impacting on this, kind of everyday way of living, and actually that negative impact that it was having. So in terms of kind of sort of, thinking about, something a bit more cheerful, relationships and social support was a really positive area, right? One of the things that we found was that people were able to talk to family members, they were able to draw upon social support from partners and so on, and this sense of kind of sort of maybe getting closer to people, actually sort of, it's strengthening in relationships, and actually sort of, people feeling that actually they have better quality relationships following on from that. And in terms of kind of sort of how that goes, the next slide after this will show that actually what that means is that actually they didn't necessarily need formal support, because one of the things that we were asking about is actually sort of, do you want to have, for example, a kind of peer support Facebook page or something like that? Do you want to go to peer support social support sessions? And generally the answer came back no. And indeed, sometimes quite a resounding no. I don't feel the need for support of strangers, right? And yeah, you can see where they're coming from. If you have ample support from your own existing social network, if you are comfortable talking with people about what's going on in your life, then no, you're not going to need any kind of sort of other more kind of sort of official version of kind of sort of what support might be. And and it's really nice to see that people are actually able to talk to family members and get support from family members. However, one of the things which we don't get here is, because this is only the patient perspective, is actually we also, and this is one of the things that I definitely will want to follow up with, is how does that feel if you were a family member? Actually, how is there maybe perhaps a need for those family members to get support in order to be able to support their loved ones? But that's I'm moving away from the data here because I don't have the data to be able to say that. Okay. So more practical things. I think I've talked about emotions, I've talked about sense of self, I've talked about the ability to plan, but they're also kind of sort of practical things. And as I mentioned, that in terms of kind of this is one of the themes which actually was not sort of universal. It was different depending on where you're at in your life stage. So we had people who were already retired, we had people who were still employed, and we had people who were self-employed. And in terms of finances, the people who were self-employed were the ones who were hit the hardest. So what we see in terms of kind of sort of the people who are already retired, they actually didn't find that, actually having had that diagnosis made a huge difference to their life. So they didn't have to give up work, and they actually didn't necessarily have a hit to their finances because having been retired, they were already used to living on a pension or whatever it might be. So in that sense, we've got somebody who actually sort of comments on that and acknowledges the fact that actually if they had been in a situation where they were still depending on a mortgage and needing to pay off a mortgage, that would have been a different kettle of fish. But actually what we then find is people who are self-employed actually really struggled, right? So what we've got is people sort of, for example, talking about, I needed to take 3 months off after my operation, and actually if you take 3 months off when you're self-employed, that's a quarter of the year, and actually the work doesn't get done, and therefore there's no money coming in for that at that point. And the other issue with that, obviously also, was there was not necessarily kind of a safety net available for those people. So they talk about going to inquire about benefits and getting very kind of sort of negative experiences of that and so on. And then we've got, in particular, this particular individual at the end who had a business, realised they weren't going to be able to carry on with that business and actually sold it off, and actually they're now living off that in terms of kind of sort of actually having that in almost as their pension in terms of what's in the bank, and actually having to live very carefully because actually there's going to be nothing else coming in. And one of the things that was significant there is self-employed covers a huge range, doesn't it? But what we found was that particularly people who were maybe working in kind of sort of labour-intensive kinds of jobs, where actually they needed to have that physical energy, they needed to be physically fit to do that job, actually they were really hit hard. So, that's something I think we need to pay attention to when we're thinking about actually sort of possibly considering interventions and so on, that we need to actually sort of check out where people are at in terms of what's important. What's nice is that we had some people talking about having had good experiences with their employers, and actually sort of people who talk about the flexibility offered by their employers, and actually the fact that they're able to continue working in terms of actually things how things operated even after they became ill. We've also got these indirect financial effects. So as I mentioned, kind of sort of it was very obvious, it was very immediate, it was direct when we talked about people who were self-employed. But actually we also see this idea of kind of sort of actually there are indirect effects, indirect financial costs that people actually maybe hadn't really sort of thought about. And actually sort of, again, it's not necessarily the sort of thing that comes up in terms of kind of sort of like the big issues. So, in terms of actually sort of going, and thinking about benefits, thinking about mortgages, thinking about those kind of sort of big expenditures, we've got lots of things in terms of kind of sort of things like, the cost of actually travelling for care, right? So, yeah, it's great. In the UK, we have NHS, which is free at the point of delivery, but actually the car parking isn't free, right? The train fare isn't free. The food that you eat when you're actually away from home for the whole day isn't free. So again, these kind of indirect things that, were things that were impacting on people's quality of life in a way that they perhaps couldn't have predicted at the time, in terms of, when they were first diagnosed. And then we've got this one, which actually, again, I was kind of surprised to see. It wasn't something that I was expecting to come up. We've got people who have to come out to the house to look after our pets. Hadn't occurred to me. Probably because I don't have pets. But actually, again, thinking about that idea that actually, when you are having to travel, particularly because we know that people have to travel quite often some, significant differences in order to access that specialist care, which is so important, that actually that means that, this is not like a 5-minute trip to the local hospital where you can jump on a bus and you'll be there in half an hour or 45 minutes, assuming the bus turns up. Right, this is actually sort of people having to really take big chunks of out of their week, and actually the knock-on effects. So not just the cost of actually travelling, but things like actually sort of getting somebody to come in and look after their dogs while they're out. Yep. So the other area, in terms of I mentioned that we have these other kinds of areas of stratification. In terms of it depends how it hit people depended on where they're at in their lifespan, in terms of what happened before their diagnosis. So we had 3 categories of people, and these were only for people who had a long-term sexual partner. So we have people whose sex life was affected by something other than GIST. In this case, it was quite often being older. We have people whose sex life was temporarily affected by GIST. And then we have people whose sex life was unaffected. And then we actually had one individual, a younger person, who was single at the point at which the interview took place. And what was interesting to hear from them was, as they said, there was no impact on their sex life because at that point they didn't have a partner. But they also talked about the fact that actually it really was possibly a big disincentive for looking for a partner. Because actually how do you actually broach that? How do you actually talk about the fact that actually, you have this serious illness, and indeed actually that it may affect the ways in which intimacy can take place. So in terms of, we've got some quotes here, in terms of the sex life changes which are temporary. So we've got, for example, somebody saying that they're still able to have an intimate relationship with their partner, and then we've got somebody talking about the pleasure that they continue to have, and then we've got this idea that actually what you might expect if you have significant abdominal surgery. Actually, it's going to take a while for you to get back to normal in all areas of your life. And so we've got somebody saying, for example, it did restrict it for the first 5 or 6 weeks, whatever. And then we've got this idea of that actually maybe depending on how old you are and where you're at in your lifespan, where you're at in your relationship and so on, actually other factors may be more important. Because again, same with the bump in the leg. We tend to go straight to, let's assume that the problem here is, or the cause here is GIST. Not always. So in this case, we've got people talking about, the fact that it's more or less non-existent these days. We've got people talking about the fact that they actually are not able to have an erection because of diabetes. And then we've got somebody talking about the fact that both partners actually have some level of sexual dysfunction, which is nothing to do with GIST again. So in terms of thinking about what we're going to do next, we have some ideas about how we would take this forward. So one of the things that I mentioned at the start is that actually looking at the difference between those stratified themes and those common themes, and actually thinking about that and thinking about how that would relate to an intervention that we might, in terms of trying to promote good quality of life, that's something that we would want to think about and develop more and consider how we would do that. And actually, part of that is how do we actually find that out? Because it's not simple enough to be able to say it's just about how old you are, right? It's actually more important than that. So it's not just about I am whatever age and I have, a full-time employment and I have a partner and I have 2 kids or whatever it might be, right? It's actually, what does that mean in terms of who you are, right? It's actually much deeper than just that normal socio-demographic data that we tend to collect as a matter of routine and actually think about. So that's something that we're mulling over. We haven't necessarily come to any conclusions with that one. But actually, one of the things that we are very clear about, and this is something that came through from our quantitative data as well as the qualitative data, is we need to actually get better at looking at how we manage those links between physical quality of life and emotional and mental quality of life, and actually looking at that intersection to see actually what tools can be given to people to help self-manage, to help empower people, to help give people a better way of actually sort of dealing with those connections in a way that actually means that they are in charge rather than the other way around. And the other thing, this kind of nice finding that we had, that actually sort of informal social support was actually sort of preferable to formal support. That's great if you have it, right? Not everybody has it. Not everybody has a loving family and social network. So again, we need to be able to identify those people who might need more. And as I mentioned also, we need to also think a little bit about actually the people providing that informal social support. Maybe there's something that needs to be in place for them as well. So that's kind of sort of our thinking in terms of kind of, you know, areas of future research that we might want to continue and develop. But as I mentioned, I'm more interested in what you guys have to think. So that's it from me. Thank you. It's me generating all this hot air.
Just turned it back on. Right, that should cool us down a little bit. Thank you very much. Can you hear me on this? Yes, good. Right, any questions?
Come on, somebody must have one.
What did you want to know from us then?
Well, I guess, was there anything there that particularly resonated? Anything there that you thought, oh my goodness, I wasn't expecting that, that's a bit weird? Or anything that you, in terms of what I was talking about, that you thought, yeah, that's the thing I think they should be working on? Yeah, that's the question.
Hold it nice and close.
Sorry, I have to admit that I was thinking I'm not going to be interested in this, but actually, I understood most of it because it's not too technical, and it entirely reflected what I've gone through, is particularly living from scan to scan. So for the first time, that's what we did. We planned our life in 6-month periods, and then I thought, life's too short to do this.
Yeah.
So in fact, I have got a holiday booked. We booked it last year. It's for September this year. I didn't know then that I got a third recurrence. But, you know, it is what it is. And it was very reassuring to see that that's what quite a lot of people are doing.
Yeah.
Having got over the initial shock is to then say, okay, well, we'll just go on until we're told not to. So thank you.
Trying as best as possible for business as usual.
Yeah.
Yeah, I think you've hit on something there. It's refreshing for me to hear that a lot of what you've just said is the sort of things I was thinking. An example is, for me, when I was first had my operation, and then I started to get scans to check to see if the tumour came back or not, or anywhere else. I was in a situation where the build-up to that appointment was nerve-wracking. Then the day of the appointment was even more nerve-wracking, and then it took a week or so for the relief for me that it hadn't actually come back. And then you start thinking about, okay, so we've now got the next appointment to look forward to. So 3 months, then 6 months. Now I'm 2 years. My next one's in December. I know exactly when and where and what time. And I'm thinking all the time, right, so, you know, I need to plan to make my mental capacity and health be in the right place for that appointment. But there's something actually I haven't said today that I normally say at the start of all the meetings that I host, which is, and hopefully this will resonate with your work as well, I always use the phrase positive mental attitude. So when I was diagnosed, for me it wasn't a case of, oh my God, I think I might die. It was, right, what do I need to do to get rid of this? Who do I need to see? How do I need to function? Who's going to do the operation? They're going to get it all out, and then what happens? Okay, I'm on treatment, and when that's over, I should be fine. Always positive and positive mental attitude, and I've found that's helped me a lot. I understand that there are people that aren't able to have such a positive mental attitude, but I would strongly, advised that if you can put yourself in that positive state, I'm a big believer that this has a huge impact on the physical being as well. And that's the reason why I try to stay positive, bearing in mind that 2 years after I was diagnosed, my wife was diagnosed with breast cancer. So she had to have the chemo. I was worse for her. For me, mentally, it was worse for me seeing her go through what she went through than it was for me. But in a way, she will tell you that she knew I could empathise and sympathise with her because I'd already been through it. You hear a lot about relationships having problems because the other partner doesn't know what you're going through. You know, you can see that for my wife, she lost all her hair and everything, but actually I'd been through cancer, so I knew what it was like to have that. I knew what she was thinking, or a lot of what she was thinking, so we helped each other cope with what was going on. But if there isn't that other partner to do that, you've got to find other coping mechanisms and ways of dealing with it. And we'll all find different ways. But I think these sorts of studies focus the mind to make us understand that we're not unusual in all these thoughts. But I guess it's, what's the next steps? What can we do? What's your advice on what we can do to help ourselves and for our families to help us and all of us cope with this sort of thing?
So one of the reasons why we do this is actually because it's not just because it's interesting, and it is interesting to me at least, but actually because we want to be able to use this information to design interventions to help support people through these processes. So, and for us, these are going to be psychosocial interventions. So we had a meeting, our research team had a meeting last week, in which we were talking about particularly this issue of what is currently a bit of a flavour of the month around fear of recurrence. And one of the things that we were talking about is, particularly if you have a rare cancer, and particularly if you have a cancer where you are on a fairly kind of sort of intensive follow-up period, a profile, is that actually it's not just fear of recurrence. And you talked about this idea of kind of sort of these kind of peaks and troughs in the weeks and days leading up to a scan, and indeed what happens afterwards. One of the problems that we have is that actually if you measure somebody's fear of recurrence, and we have the scales to do this, in the run-up to a scan or some other kind of checkup, it'll be off the scale, right? Of course it will, right? And one of the things we need to do is to find ways to help people self-manage, actually to build on what we know about what can be done. Not to say that actually people shouldn't be worried or shouldn't be concerned. Of course that's a natural response, but not to the point where you can't function. And one of the reasons why this is important is because, and I don't know again whether this is going to resonate, but what we have heard is that actually when you're in that situation, that really heightened situation where you're kind of sort of, you know, the adrenaline's pumping and it's the fight or flight kind of sort of mechanism has kicked in, is when you then go into that meeting with your oncologist or whoever it might be, you hear it's clear, everything's good, and you don't hear anything else, right? And the problem with not hearing anything else is because there may be important things to discuss after that, but because people are so focused on that, you know, that main outcome, understandably, naturally, the rest of that appointment is basically a waste, because actually people have disappeared. They've kind of left the room. They've heard what they need to hear, and they're out the door. So what we are aware of, and this is practice which differs around the country, but some trusts, for example, have a system whereby the clinical nurse specialist gives the actual official, you know, your scan is clear, the week before. So they're able to get that information, they will actually feed that information back, and obviously that's done, you know, by the clinical nurse specialist because it's important in how that's done and so on and so forth. And what that then means is that when you go to your actual meeting with your healthcare professional, you're in the room, right? You have got that information already, and actually you can therefore manage your anxiety to, you know, in such a way that you can actually have a useful conversation, talk about kind of sort of what's going to happen next, talk about treatment options and so on and so forth. So things like that, which are kind of sort of not rocket science in terms of actually just actually changing the timing of that information being provided, are ways in which it helps people self-manage, right? So again, you know, that's something that we're also thinking about. The other thing that we were talking about last week is actually, you know, apart from those kind of sort of points where actually sort of people are really kind of sort of in the peak rather than actually sort of their general kind of level of worry, what we're dealing with is not necessarily ongoing fear of recurrence. There are some people who actually do have ongoing serious fear of recurrence, and that is something which is a clinical level of anxiety and needs to be treated at, as a clinical level of anxiety in terms of actually sort of, possibly medication, possibly other ways of treating it. But for most people, what it is this kind of background worry and this kind of sort of influence on kind of sort of, how do I actually get on with my life? And actually what we are trying to develop and what we're looking into, and we're actually doing a pilot study this summer, is interventions which will help people deal with that kind of background worry, that kind of sort of, I don't want to call it low level, but kind of sort of the background hum of kind of sort of always having that in the back of your head, and how that makes you feel about sort of being able to do the business as usual and actually get on with enjoying the things that you want to enjoy. So that's kind of sort of a slightly long-winded kind of answer to your question, sorry.
I'll hand over to you. Forgive me, tell me if what I'm just about to say sounds really weird. Contrary to that, I have this feeling in the back of my head sometimes that if I do forget about it, and I do just get on with life, that suddenly it'll come and hit you like a rocket and you get diagnosed again with it. So you're at that point of, I don't want to forget about it, because if I do, sod's law will hit and it'll come back. Does anybody else have that feeling? No, it's just weird, isn't it? I'm supposed to have a positive mental attitude as well, but that does enter my mind sometimes.
But that's part of it. I think when you are sort of really focused on actually bringing your own attitude and your own kind of source of strength into it, actually, it's kind of like, well, I have to be doing this all the time. Yeah.
Hi.
Hi.
Is this working? Yeah. Everybody hear me? Yeah. Good. You mentioned this question of regular scans. Yeah. There's something else actually which I think is more wearing than in fact the periodic scan situation, which I've already adapted to, having just had my third. So I'm no longer, at least consciously, anxious about that event, because que sera, sera, it will be what it will be. It is, for me, looking at the longer term, because I'm on a 3-year program of imatinib, so it's not a question of looking every 3 months. It's a question that my life has changed, if you like, forever, in a sense. Yeah? And I have a positive mental attitude, so I made my decision not to give up any of all the things I'm involved in, and I made that decision 1 month after the operation. Okay? It's not an issue, but what does wear me down, and on one occasion I did actually drop a tear in front of the oncologist, okay, because he said, so how are you? Yeah? How are you? Okay? And dealing with these side effects day in and day out, okay, it wears you down. It really does wear you down. And you're very brave and you try and carry on your life in the normal way, then suddenly it catches up with you. And on this particular day, how are you? And I suddenly thought, I'm carrying this huge burden, yeah? And I've got to live with it, and it's not to the next 3-month scan, it's at least 3 years. And the positive aspect about it being on a 3-year program of imatinib, when you tell people you've got cancer and they say, oh, yeah, is that, no, at least I know that maybe I'm going to be around in 3 years. It's not one of these cancers where I've been given a prognosis of not being here in 12 months, okay? And the other thing, by the way, in terms of positive mental attitude, having decided that I was going to share my experience of my cancer with the people around me, okay? I've got to a point now, I saw on a slide or somewhere about this question of, when people say to you, okay, how are you, yeah? So my answer to them now is, straight away, I have a 10-year plan.
I'm glad you do. I think we could all kind of sort of take an inspiration from that. And I think actually, can I just also add to that, because I think one of the things which is, which I didn't talk about today, I could have included a slide on, is this idea of kind of sort of, yes, people are getting support from their social networks, but when you have a rare cancer, when you have a cancer that nobody's ever heard of, when you have a treatment that people actually are not familiar with and actually is unusual compared to sort of the more popular common cancers that people know about, quite often there is a burden to educate the people around you. So when you said, for example, when you tell people you've got cancer, they get the shock and horror kind of face. And actually, when you then say, oh, yes, but, I've got a 3-year program, blah, 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 you almost are having to do like a little mini lecture for everybody who you come across in order to give them the information that they need in order to either to respond appropriately and also to be able to support you. And that, I think, can be a burden too, the need to kind of constantly be educating the people around you.
There is a downside to that, and that is that more of the involvement that I've had with Just Cancer UK and the other charity as well, I've realised that the sooner somebody is diagnosed with a cancer, the quicker they can get treated, the more chance they have of survival. Simple as that. So I spend a lot of my time talking to friends, colleagues, golfing mates, etc., about any feelings of unwell that they might have, to go and see the doctor. What happens, though, is that when I turn up at the golf club and I haven't seen somebody for a month or so, that person will say to me, oh, Nick, how are you? How's you? Everything okay with you now? And I go, yeah, no, it's... And before I start my question, somebody sat there goes, oh, God, is that Nick going on about his bloody cancer again? And you're sat there thinking, okay, so I need to answer his question because he's concerned and asking me how I am, but he's getting pissed off with the amount of people that are asking me about my cancer. What do I do? So I made the decision. I actually said to this person, because he said it on more than one occasion, well, let's hope you don't get cancer, because I'll tell you, you will want to know all you can about it if you do. He never said it again after that. But I don't let that now ever stop me talking to people about cancer. And every time you don't feel very well, go and see a doctor, because it could be something serious. Hopefully it's not.
I think also, you obviously have made a conscious decision to be that person. But there's another quote which sort of comes into my head in terms of some of the data that we did, is somebody talking about, I don't want to be the cancer guy. And actually, that sense that kind of sort of they didn't want their friends and not necessarily kind of close people, but the people down the pub, the people who were in the pub quiz team, they don't want them to see that person as the cancer guy. They want that person to see them as Dave or Tom or whoever they are, the same as they've always been. Yes, he happens to have cancer. Yes, he happens to be going through this, but actually, is he really good in our sports round? That's what's really important today. And actually that sense of kind of sort of, people, yes, acknowledging it, recognising it, and hopefully being sympathetic and supportive, as opposed to perhaps your other friend who's not quite so much. But not losing that sense of who you are as a human being as well. Because actually not everybody necessarily wants to take on that educational path.
He just thought it was being funny.
Oh, yeah, well.
Let me just preface what I'm going to say. Everybody is different, and I think that there's a danger when you say, and you're going to speak to someone like speaking to Nick and saying, and how are you? And I'm inclined to be a kind of person when someone says, and how are you? In fact, in that case, it's my wife who's the patient, if you want. So when someone says, and how are you? I'm saying, well, I can't put, I've got a difficulty with put. The idea of the cancer doesn't come up. I'm more than that, and I think the majority of it are more than that. Absolutely, yeah. But it's there's a danger of defining your life when you talk to other people and say, oh, my partner is a cancer patient, or so-and-so is a cancer patient, and a reluctance of some people to approach you on the grounds that, I don't know what to say to them because they might get upset about it. The fact is, most of us have got lives. The cancer is such a small part of it. You say, well, how are you? I said, well, yeah, I've got a problem with my clarinet, or I've got a problem with whatever. There's far more to it than that. And it's so easy to let someone define the lives by what's just happened. The thing is, what you've done for the last 30, 40, 50 years, that's your life, as much as what's happened since you've had the diagnosis. And the early part of your statement talking about we need to have some intervention in order to deal with this new thing that's come along, which is cancer. And I think that for the majority of people, it's just another thing in their life, and you move on. And there's just everyone is different. My brother's going through one of these issues, and we just say, well, that's the way it is. And I'll quote what he says. He says, when you're playing golf, he says, well, on the right side of the grass, that's good enough. And I think that one way of dealing with it is by not necessarily playing it down, but certainly not focusing on the actual thing that's going on, is because there are far more important things. This is just another thing, and not everybody needs these specific coping strategies, because subconsciously we've been dealing with things like failing an exam or failing your driving test or these things turning up or nervous before an exam. Everybody's got coping strategies. This is just another one. It doesn't necessarily need to be formalised as how we deal with these things. That's all I'm going to say.
Can I ask a cheeky question? How old are you?
80. That makes a big difference, yeah.
That actually people who are older had better coping strategies and were actually better able to deal with those things, and probably would not be the target of our intervention because they don't need it. And I think, what you said about sort of, having those kind of had life experiences in terms of kind of things that have happened before, actually having found ways to cope, you've actually sort of got to the age of 80 by actually sort of, developing your coping strategies and finding out what works for you and what doesn't work for you, actually is something that we saw across the board, and certainly in terms of the assessment that we did of fear of recurrence. One of the statistical analysis that we did was that the older you were, the less likely you were to have fear of recurrence. So I think there is definitely an age thing there. But again, I don't think it's necessarily a number. I think it's also to do with kind of sort of maybe kind of the nature of kind of sort of the experiences that you've had before, which have built that kind of sort of resilience in terms of kind of sort of where you're at when you get to the age of 80.
It's subconscious as a result of experience.
As his other half, I can just say he's the most laid-back person ever. So, anyway, I would just ask a quick question. In your sample, you had 8 men and 2 women. Yeah. How did that? Do you think that had any impact in your feedback?
For some of the participants, it was very clear that this was they were talking as men, yeah. So, and indeed they would say that, right? But for others, if you had not known that they were male, you probably wouldn't have been able to guess. So I think the answer is yes and no. Which sounds like a bit of a cop-out, but actually, yeah, I mean, certainly, as I say, it's unusual for us to have such a high percentage of males taking part, and it's certainly something that we would like to do again and get, maybe actually do the same interview schedule, but with actually a 100% female population.
One of the things that we've been talking about in GIST Cancer Trustees, etc., is how women perhaps will talk about things. So in our meetings that we have in a minute, the women tend to be a bit more forthcoming and will talk, and that is a known. We know that girls do chat, don't we? And sometimes and sometimes it's more difficult for men to actually express their emotions and chat. So I just wondered whether or not you'd actually come across that aspect when you did it.
We have, and I mean, I guess the other thing I suppose we should say is that actually sort of it is likely that those men who volunteered to take part in these studies were probably not your average men. I mean, in general, anybody who volunteers to take part in your research is not your average person. We're all a little bit weird if we're interested in research. There's something about us. I'm a researcher. I'm chief of weird, right? So I think, you know, from that perspective, they were men who were talkers, and as you say, that is not necessarily the case for you know all mankind. But I think, you know, that's one of the reasons why we were quite pleased, if you like. And the other thing, again, if we're thinking about sort of, you know, potentially sort of considering support, making support or designing support which is focused and actually useful, is to look to see actually, are there gender issues that we need to pay attention to. So you know it may not be, you know, having a, you know, a support group may not work. So you know what's interesting, and you know, I think, you know, there were days when I was maybe a little bit cynical when I was doing the analysis, where I was reading over and over and over again, well, my wife is wonderful, well, my wife is wonderful, I get all the support from my wife. And I was thinking, okay, I wonder if we should be hearing the same things from the women. Would they also be saying, my husband is wonderful, I get all the support I need from my husband? And actually, that's probably just me being nasty. But actually, you know, again, we do know, unfortunately, that when, particularly with cancer, but not uniquely to cancer, is that when a heterosexual couple are hit by an illness like that, men walk and women don't. And actually, sort of, you know, if there is a marriage breakdown, it's usually because the male partner leaves. And actually, so I would be interested to find out whether that's that informal social support that came through so strongly and actually was given as a reason for not needing formal support would also be the case if we had more women in our sample. So it's kind of an open question for us at the moment.
I want to know about support for carers, for family. Yeah. My daughter has been wonderful, but I don't know what support she gets. Her husband is very supportive for her, but she's a solicitor, she's got a stressful job, and I worry that she's not telling me how worried she is, that sort of thing. I'm well, I've had surgery, the gist was removed with a good margin, and as far as I know, I'm fit and well. But I do worry about her. And my son, of course, he lives the other end of the country, and being a man, doesn't talk that much. You know, it's, are you okay, Mum? and that's it. He doesn't tell me how he's thinking about it.
I think that's definitely something that we want to explore more. And I think there is an issue. For example, when you think about sort of, you know, funding for research, psychosocial research doesn't get the big bucks, right? Fine, most of it goes on looking at sort of treatments and cures and things. I'm not going to argue with that. But actually, even when we look at psychosocial support, the idea of people who are not technically cancer patients is kind of sort of they're way down the list of opportunities to get funding to do research with them. And the only thing, or kind of one of the things that we're kind of sort of looking at the moment, is what we have found, not necessarily in this sample, but in other samples, is people saying, actually, yes, my family is supportive, yes, my family is there for me, but actually I don't want to be a burden, which is a bit like what you're saying,
that's
actually.
Right.
And actually that sense of kind of sort of, you know, you can't utilise that wonderful social support if you actually are worried about burdening people with, you know, with your needs. And that came out of particularly when we were talking about fear of recurrence. People were saying, yes, actually I am concerned, yes, that is something that worries me, but I don't want to tell my partner, my daughter, my sister, my whatever, because actually I don't want them to worry on my behalf. And actually, in that sense, if we can support the social circle, the family circle, then hopefully that will have a knock-on effect and mean that they can therefore better support the patient as well. So I think this idea of kind of sort of, you know, we need to do a better job perhaps as researchers of explaining why this is important. It's not just a kind of sort of, oh, it's a nice nice to have, would-be add-on kind of sort of thing. Actually, it matters in ways which maybe are hidden a little bit.
Yeah. One thing which did upset my daughter, she comes with me to consultations because of my hearing, and you know, the surgeon was talking to her and said, oh, do you live nearby? And she said, well, you know, about half an hour away. Box ticked. She's got local support. And when I came out of hospital, it was assumed that she would take time off work to look after me.
Yeah.
And she couldn't. You know, well, she did her best, but I got no support. And that was stressful for her, you know, because she felt guilty.
Yeah, but again, assumptions being made about what was in place without actually asking.
Well, exactly.
Yeah.
That really annoyed her. And she said if it had been her brother who'd been with me, that assumption wouldn't have been made.
Yeah.
You know, do you live nearby? Yes, 10 miles away. They wouldn't have assumed he would look after me. Anyway, thank you. It's been really interesting.
Thanks.
Any final questions? Yep.
Thank you. I just thought it's really interesting when you said about what stage of life you're at when you're diagnosed, because the median age, one of the earlier speakers told us, was between 60 and 65. Well, I was 39 when I was diagnosed, and I had young children working. I'm still working now, and I just that interested me that you looked at that, because that's a whole new set of emotional and psychological challenges, and because of financial, economical impact, responsibilities of motherhood, and also bringing in, you know, the household income, and doing all of that while still being treated and, you know, going to all your hospital appointments and that sort of thing.
And I think one of the things that we have found is, particularly if you are in that really kind of sort of full-on period of life, and it's something which is important to you, something which you know you value and is important to kind of your sense of self as well. Actually, that's something which needs to be passed on to your healthcare providers, all of them, and actually make sure that they know. So it's not just about kind of sort of, oh, you know, I'm going to need to arrange childcare in order to get to my appointments. It's also about kind of sort of what that means in terms of that sense of kind of, who am I now? For example, if we just take the most kind of sort of, almost crude, basic kind of ways of thinking about it, I have gone from being the nurturer, the person who provides the care, to being the one who needs it. And actually that flip can be really challenging, and it can be particularly challenging at that point in terms of kind of sort of, the developmental kind of sort of processes. Because again, I'm not trying to say, oh, it's okay, it's easy if you're older, it's easy if you're retired. It's different. And I think actually it's just that recognition of what that difference looks like, how it feels, and the impact that that's going to have. So I think, and I think, you know, again, because, I mean, not just for GIST, but in general across the board, cancer tends to be a disease of older people. As you mentioned, the statistic in terms of kind of sort of, being in the 60s for diagnosis. It's kind of a lot of the kind of support, a lot of the kind of sort of help that's in place is kind of based around that idea that we're dealing with people in the second half of their life rather than the first half of their life. And that's fine, but it isn't going to work for everybody. And actually it really needs to be interrogated and looked at again. And again, just sort of recognizing that actually sort of we need to perhaps have these kind of sort of more in-depth conversations with people about who they are and what's important to them, and what's, kind of sort of what, what's going on in their life now, and actually, just build that in. So again, that's one of the things which is kind of, it's not necessarily easy. I mean, I wouldn't pretend it is, but actually, it's something that we want to be paying attention to.
Yeah, like you said, on the plus side of that, although it presents a lot of challenges, I found one of the ways that I could cope with that period is because I still had to get up and go and pick the kids up from school, and they're just oblivious and they carry on, and so, swings and roundabouts. But it's different ages present different mental challenges.
Exactly.
I think. Yeah.
Okay. Any more before I walk that way? Is anyone up here? No. Right. Okay.
You're going to shut me up now, Nick.
No, I'm going to thank you very much for your talk today. We're trying to involve the mental health side of dealing with a cancer diagnosis more and more, because if COVID taught us anything, it taught us that mental health was a really important part of our overall health. So thank you very much for coming. Thank you for giving us your talk.